I don't think there's anything more I need to tell you about that. Let's get going, and here's my plan for the discussion this morning. An overview of PATH, which I think I'm going to truncate a little bit here, and then the RSV vaccine project at PATH. RSV intervention development challenges, and then the time frame and context, which I think will be very of key interest to this group. So a little background for this group, and I'm going to truncate this a bit. I think this community in particular probably has seen us in the past at PATH in terms of vaccine development. I just want to make sure you're aware PATH is broader than vaccine development. Our focus is on improving the health of women and children globally. We work in 70 countries around the globe, focuses mostly in Asia and Africa. We have 1,400 people globally in our organization. Half of those people are in place, in country, and of those in-country people, 95% of them are local. That enables us to do some of this work that's coming up and some of the vaccine development work in a capacity that other organizations don't have. The thing I wanted to drive home here is that we work across 5 platforms at PATH. Not only the vaccines, but we have drug platforms, diagnostics to make sure that disease is diagnosed and appropriate care and treatment are provided. We develop devices that improve the health of women and children in the developing world. And not only that, but we are involved in systems and service innovations that bring and enable these interventions in the developing world. I've listed here across our vaccine programs the vaccines that we're working on. I've highlighted at the bottom the vaccine programs that are relevant to maternal immunization. As we all know, millions of deaths can be averted and if the right vaccines are developed and made affordable and accessible in countries. Often the vaccines that are available in the Western world are not made available as quickly in the developing world. So we want to make sure that we can address that need. The issue that a vaccine that might be developed for the developed world is not relevant to the developing world isn't the case with RSV. RSV is a global disease, so what is developed for the Western world, we need to be able, or we will be able to implement or use in the developing world. I'm going to go on here, and now let's focus in on RSV. So at PATH, our focus is the niche of trying to address need for the youngest infants. So we are looking at that under 6 population. And the way we've shifted, and I want to say and congratulate this community that 5 years ago when I joined this community, the interventions weren't as far along. I'll show you what that landscape now looks like. You've hopefully seen it more recently. But PATH is now shifting focus beyond the vaccine development piece. And so the areas that we're looking to address now are this area that Vasi mentioned is very key. With vaccines that are moving along, interventions that are moving along, we need to be able to look across them. So the RSV assay standardization and harmonization work is still a major component of our efforts. But also this issue of adding to the value proposition for the vaccine. So clarifying the link between RSV and wheeze asthma in the long-term sequelae. And as well, working now to provide the evidence and support to advance global policies, as well as assessing country-level needs and challenges. So here is the current version of the RSV snapshot. We keep this posted on our website. It is a resource we make available to the RSV community with your help. It is updated approximately twice a year or whenever an intervention changes stage. So you let us know and we will update that snapshot. We currently have more than 16 RSV vaccines and 2 monoclonal antibodies for passive immunization in clinical development. We have multiple phase 3 studies in progress. Marketing approvals for new RSV interventions are in the foreseeable future. This is significant progress in the field. But having an intervention licensed or marketed is only the beginning, the first step towards the solution. So we need to ensure that RSV disease burden must be understood and recognized to engender the need for these interventions. And as I said, not only do we need them to be available, we need recommendations by global, national, and country policymakers, and these interventions need to be affordable, accessible, and acceptable. And I'll talk a little bit more about this, and you're going to see a lot of overlap in what you heard from Vasi this morning. So, and I called these challenges beyond licensure, but I think I don't want to imply this is insurmountable or difficult. We just need to be forward-thinking and plan to be able to address these in an appropriate time frame. So the RSV disease burden, getting additional information to understand these needs that the global policymakers are going to need. I want to remind you that 99% of the mortality occurs in the low and middle income countries. And there is a need for increasing surveillance to establish the background rates of RSV disease. Vasi did talk about how the global influenza surveillance system, it has implemented a pilot project that is looking to increase this information. We have a need for age stratified data, particularly in the first year of life, and we need to increase the community data on mortality. Burden understanding, as was pointed out by Vasi as well as Nitin, that we need to look not only at mortality, but we need to include the morbidity burden as well. And all I've done here is list some of the ongoing known activities related to increasing that understanding of RSV burden. You've heard from Harish in terms of the work being done by the RSV Gen Network. You've heard about the CHAMPS work being done that's being funded by BMGF. I've already mentioned the global surveillance being done by the Flu Surveillance Network. And the other piece that hasn't been discussed as much at these meetings is the Innovative Medicines Initiative that has begun that will add to the burden data available for the EU, but as a shadow activity of that, what Harish has set up is there are a lot of associate members with that organization that will be trying to implement this type of information to be available in low and middle income countries as well. We talked about how vaccines need to be available, and Vasi talked about as these interventions are moving through the pipeline, people, organizations, developers, regulators need to be able to look across these interventions to compare data and prioritize. And so the assay standardization work is going to be key for that. I hope you all got to see Nancy's poster that was up on Thursday, perhaps heard her key summary that even though there are diverse NEWT assay formats out there, it appears that standardization with an standardization or harmonization with an international standard is feasible, and WHO and NIBSC are moving towards a collaborative study that will be implemented, I believe, in early 2017 to establish that standard. So materials will be available to do this. The other thing related to that, the same thing needs to be done with other RSV assays, because we need to look at other information that may provide correlates of protection. And so PATH is undertaking a similar study for the palivizumab competing antibody assay, and we anticipate having preliminary results in Q2 of 2017. But again, that needs to be done with additional assays. It's not the end of the road for those future efforts. We know that vaccines moving through the pipeline will include pre-F or G proteins, and those assays have to be there and standardized or harmonized as well. Okay, the interventions must be affordable. So we have to develop the value proposition for global, national, and local decision makers. As Vasi pointed out, we have the Gavi 2018 VIS staring us in the face, not very far away, and need to put that information together, and we've got clarity from SAGE about what they'll be looking for. And so the cost of the intervention, the anticipated impact, you heard some of the early modeling work that Clint has begun putting together, and then cost effectiveness evaluations, so that these global policy makers and funding decision makers have what they need to be able to do that. And the other thing that I think Vasi may have mentioned was Gavi has asked that the information be put into the intervention information and be put in context with other interventions, so that allows them some perspective and will allow also countries to make prioritization decisions. Ways to increase the value proposition, I think Clint went through some of them very nicely in his model, but some outlying pieces that weren't discussed were answering questions as simple as not simple, but including whether pregnancy, the vaccination provides a benefit to the pregnant woman. We know women are willing to accept the risk of vaccination for the benefit of their child, but we could add value if there was a benefit to the moms as well. And an advantage we also see with RSV vaccines is these are the first maternal vaccines that will actually have a label indication for use in pregnancy. So perhaps the hesitancy that might be seen with flu vaccines will not be so carried along with this vaccine. And then understanding the impact of the intervention on asthma wheeze. I won't go into again, you've already heard that. And then the other thing is optimizing performance of the interventions to maximize their feasibility and acceptance, and that could be the duration of immunity or the ability to be co-administered with other vaccines. So if we only get one chance to immunize these women in the antenatal care system, we can't have a conflict with the other vaccines that we might want to implement at the same time. All right, and then finally, interventions must be accessible and acceptable. So we need to conduct formative research to identify the appropriate platform and deliver interventions. Now we know, as I think Clint mentioned, it's likely that these interventions, whether they're maternal or a monoclonal antibody birth dose, these are likely to be outside of sort of the EPI, the typical intervention platforms, and that might add additional cost to the deliveries. So we need to understand what that looks like. And then we need to assess feasibility for being able to deliver, including whether what the platform, the delivery platform strengthening needs might be, the human resources required, the supply chain logistics, and consider, as Clint already mentioned and I think explained well enough, I don't need to go into it, does layering this onto the platform mean that some other valuable component has to be displaced, and that needs to be avoided. So we need to evaluate community acceptance, the priorities, and the national for national decision making. And then the other piece that's important is that we disseminate the evidence through the appropriate and effective communication and advocacy when the time is right. Here's the slide I wanted to show everyone so that you understand that it's an ongoing process that will take time, but it has different stages and we can target meeting the needs in the time frame. So at the top you see vaccine development moving along. Underneath, at the same time, we're building the evidence, and then we're working on the timing for policy and finance. We've got the SAGE and Gavi interplay that will come and go multiple times as time goes on, and then delivery underneath, trying to meet those global and country needs to ensure that we can move these interventions into the developing world in a timely fashion. And I think that's my last slide. Thank you.